Okay. Good afternoon, everybody. We have small group, so it's more opportunity of having more discussion. So definitely we would like to listen from you also. My name is Falak Nawaz, and I'm working as a executive director of network of disaster management practitioners in Pakistan. We are working in disaster management since last year, but personally, in personal capacity, I'm working in disaster management since last 24 years in Pakistan, but also outside in Pakistan and many countries. Earlier, I was working in Asian Disaster Preparedness Center. So this was my introduction. I would like to share a case studies, in fact, with all of you, which we practice in Pakistan in one of a province that is called Khyber Pakhtunkhwa, where it is always very difficult to work, especially when you are engaging women in the disaster risk management practices. It is always very difficult, and especially we were working in a communities where only 1% is the literacy ratio. So you can imagine that how much it is difficult to engage where especially the cultural barriers is one of a big hurdles, especially for women, where they cannot expose to different platform, although they want to participate, but it is always very difficult for them to expose to these kind of environment. So we try to, within 2 years, try to engage them, mobilize them, building their capacities, and we can see that we have now a trained woman who are very trained in first aid, search and rescue, fire safety, and they have attended 13 days medical first responder course. So you can see that it is a very extensive course which they have attended. So we try to build the capacities of these women in this project. So this is can you, madam, click one more? So this is on the background is the Pakistan map. This boundaries, it's a satellite image, but some of you, if you have visited Pakistan, it's a beautiful country. On the north, we can see the glaciers, and we have seen, you can see the second highest mountains in the world, and the 8 highest mountains are situated in Pakistan. And in this month, even you can see 0 degree centigrade temperature in northern Pakistan, June, July, where it's so much cold. And similarly, on south, you can see desert and barren land where the temperature in these days is 52 degrees Celsius. So you can see two different differences, that 0 degree centigrade in 1 month and then 52 degrees Celsius, and the peoples are working. So we have diversified topographical features. We have deserts, we have glaciers in all these colors. You can see this is all glaciers. So climate is very, very uneven population density. We have big city like Karachi, where the population is like Bangkok city. So it's a very, very big city. And then Lahore is a very big city. But then there are certain places where you travel for full day, but you will hardly see any human being. So it's like a very uneven population distribution. We have unplanned development, especially in the disaster-prone areas, because we have mountainous area. River system in Pakistan. 5 major rivers are flowing, which is originating from India and is coming to Pakistan. And all population is living along these 5 rivers. So you can see that uneven population distribution and then unplanned development. So as a result, poverty is also there. The vulnerability segment is very high. And then the pressure on the natural resources is a big country. So definitely the resources is dilapidating quickly. And then especially in our case, we have lack of awareness on the disaster risk management. Reactive approach is very dominant in Pakistan. When it is something happen, then normally organizations or communities are coming to action. So this just the one slide on the WHO and UNESCO and UNDP in joint collaboration, we were working together, mitigating adverse impact of prolonged internal conflict in Pakistan by fostering peace and multi-sectoral development at community level, leading to improved human security. Because we have IDP crisis from the mountainous areas. Because of the insurgency, they moved down to the city areas. So when they migrate, also there are problems. When they settle in area, also there are problems. So this project is related with that. It was running in 2014 and 16. So as I mentioned that there were three organizations, UNDP, WHO, and UNESCO. So we were working with the WHO on this project, and it was called as Engaging Community Health Workers in the Disaster Risk Management. And this, our organization, Network of Disaster Management Organizations, we were providing the technical services. So just want to ask you a question that when we talk about community health workers, who are they? What do you think that community health workers are? Definitely one are community volunteers, but what else? Community health workers. Yes, any idea? Yes, sir. Who you think that community health workers can be? Definitely the members of the community, but especially the volunteers of Red Crescent and Red Crescent societies who normally train, who are working with the communities, but they are more focused on emergency response. Okay, and then also they are working in health sector. Who else? Yes, doctors can be, but you know they are not working directly with the communities, especially with the rural communities. They are not working. They are working more at the maybe sub-district level or beyond that. No, midwives. Yeah, Red Crescent volunteers is very active, especially with the health sectors. They are providing services, and you know that they are very much having a best medical first responders. They are very, very good in that. And then also in your country also maybe like we have lady health visitors, we have lady health supervisors, we have lady health workers, we have trained birth attendant. So you can see that these are especially in a rural communities and especially in Khyber Pakhtunkhwa province, which is very remote northern province where normally the women, they never go to hospitals for delivery, and they have to depend on the this trained birth attendant and lady health workers for pregnancy. So you can see that these are the barriers which is existing in these remote communities. So we try to engage them, and the reason is that these community health workers, they have local knowledge. They are working with the community. They are from the community, so they knows everything about. And also these community health workers, especially this lady health workers, they have very basic data of each and every house. Number of children, number of pregnant women, male population, older people, all these data they have each and every house. They are able to take action with the help of community and local level disaster management committees. In Pakistan, as we are now institutionalizing from national level up to the community level. So disaster management committees are in process of forming at the community level. They can help community to prepare and well organize to reduce the health risk. It is very important, especially for the pregnant women, where they don't know about, they never care about their health. So they are the motivators who can especially reduce the health risk and especially impact during emergencies. Because when they displace for 2 to 3 months, 4 months sometime, because of flooding season, because of internal conflict, because IDP crisis is very common in this district, and they can save many lives in the first hours after an emergency. Before external help arrives. So we train them in first aid, in search and rescue. As I mentioned to you that 13 days medical first responder course and 9 days CSSR collapse structure and search and rescue. So it is a very detailed course which we train them in order to able them that how they can help their communities in the health perspective. Next, please. So this was our approach, that we try to build the capacities. And initially when we engage these women, you will hardly believe that if we are inviting 10 women, then there will be 30 male also who will be joining. For example, that lady, brother, husband, or father will also be sitting with them in the training. So you cannot ask them to conduct a separate training for them. So it is so much difficult. So we start from that level. And gradually we build the rapport. When they understand that they are doing some good things, they want to train our ladies, then they were sitting with us alone. But at the initial stage, you can imagine that when we are giving training, then also their male has to sit with us. So this is in phase 1, 2 phases. So we develop for them is HCBDRM, health-based community, the disaster risk management courses. And please, this is also available on the WHO Pakistan website in English, but also then we produce it in Urdu. So feel free, you can use it because it is a training toolkit, trainer manual, and then participant workbook, and then PowerPoint presentations, all are available. So that is also under the WHO we have developed. And it's basically just one question I want to ask you, that I mentioned to you that the lady health workers, lady health supervisors, lady health visitors, the Red Crescent Society's volunteers, what do you think, how they can play a role in the disaster risk management with us? What they can play a role? Yes, madam. In health perspective, what type of role they can play with us in the DRM system? Yes.
They are all the, I want to add another community-based model, which is Mali, adapted by the hand. So we have more than 20,000 trained Mali workers in all, around the, you can say, the Sindh as well.
Okay.
So they are the best in community. After they are based in the community, they are belong with the same community, and they knows very well the problems and challenges to the community as well as to the concerned village and the area as well regarding disaster. So after the training, they will contribute. They will aware to the local communities and regarding the DRR buyers and as well as the DRM perspective. So they are the, and then actually they are the community leaders, because the community realize them as a they are the real their leaders, though they can follow each and everything identified by them.
Very
so they can play the vital role for us.
Exactly. So we also try in the same way, like normally we conduct MHVR, a multi-hazard vulnerability risk assessment. But once, as I mentioned to you, that these are the women, they are the workers who has all type of data, each and every house. So when we are talking about risk assessment, we need house-to-house data of villages. When we want to conduct risk assessment on a very micro level. So we engage them that, yes, you are collecting data, that is very fine, that is good for your purposes, but then in risk assessment we utilize them. That how, because they have data, so we ask them to put some more questions related with the risk assessment about the hazard assessment, vulnerability assessment, exposure, capacities, and finally risk mapping. So we have seen, I have all these records with us that how these, on the basis of that, we have conducted full district MHVRA these days. The government of Pakistan is conducting multi-hazard vulnerability risk assessment of certain districts. So this district is, so those information which is collected by these community health workers are very useful for us. What else they can do? Yes.
Just a question, are they mainly focusing on health in emergencies as a result
Yes.
of natural hazards?
Yeah.
Or are they also dealing with epidemics or dealing with
Both.
health issues? Because these are very diverse.
Diverse. No, in both cases.
Dealing with both at the
Exactly. The reason is that, as I mentioned to you, that this is for the IDPs. So they are also dealing with the, beside natural hazard, all human-induced hazards, including epidemics and pandemics. So yes, in both cases, like we just use them for risk assessment for natural hazards. But then inside, like for water quality, we use them as a researcher. And they collect samples from different villages, and then we test it in the laboratories, and we saw that water is very contaminated, and there are many diseases associated with that contaminated water.
I'm asking this question because within the Red Cross we have either people who are more in the DM on disaster management side or health background people, and it's hard to combine
Yes.
both, and then sometimes they always have like a bias towards what their background is or their personal interest is. So I'm quite interested to see how you can find the right balance between people looking at natural hazards but also taking into account all the health aspects.
Exactly.
It seems like a daunting task.
Yeah, exactly. And this is in fact the main idea also, mainstreaming these people. We ask them, think out of the box. The normal routine you are doing, you are dealing emergencies, you are dealing the medical cases. But then we utilize them, what is your positive role in emergencies? Not only during emergencies, before disaster, during disaster, and after disaster. So if you look at to this material which we have developed, that is all focusing the role of community health workers in the overall disaster management cycle. What activities you should do before disasters happening, during disaster what you will do, and then after disaster. So it is really very simple book. I will encourage you to please, you can collect from me also. You can write to me. I have in my computer also, I can give it to you. But it's very simple books which you can utilize it for the community level workers, that they can also can be a good force for us in the disaster risk management. Because when we are talking about the DRM, we say it is a cross-cutting theme. So they are very effectively, they are thinking from health perspective, but then in the DRM system, how they can be fit in. That is, we utilize them. So we develop this material for them, and we then give them training of 6 days on HCB DRM. We select master trainer. We initially engage them as an assistant trainer, slowly to increase the capacities. And then we are trainer, but they are just assisting us in 7, 8, 9, 10 courses. And they are just assisting us in some group activities or maybe recap or something like ice breaking. And then once we build the capacities, they get confidence, then we involve them as a full trainer. And until now, it's project finish in 2016. But we try to propagate for other NGOs also to utilize them as a trainer, as a master trainer. So we have really seen that now those ladies which never attend any course without their husband or brothers, but with us now they travel to other provinces. At least in my capacity, we are using them until now. So it's very good approach that we follow. So we have now these master trainers, and then we replicating now. In 2 phases already over, now third phase, we are trying to find some funding source. Next, please, madam. So we, just a quick, I will go through, madam, I have up to 4 o'clock, right? So yeah, 15 minutes for question answer we can also, yeah, 4 o'clock, right?
No.
3, no, 2:45? 4, no?
Yeah, understand.
4, no? 45 minutes.
So it's 40.
10 more minutes.
40, it's
3:40. Okay. So it's a short time. So we built repo, we did baseline survey, and also we met with the, can you please go next minute? So we also with the deputy commissioner, the district government officers, health department personnel, in order to engage them so that we could get serious people for this project. So you can see that this is all sensitization, orientation at different level. We organize orientation workshop for the health and disaster management practitioners, where 22 participants attended this workshop in that district. And these are those manual which I mentioned to you, that it is in English also, and it is available in Urdu also, and on the website you can also find. The second, we develop this material, and then we build the capacities. And as I mentioned to you, that we have conducted training courses, 18 HCBDRM courses we organize, and 6 training courses on water quality and promoting hygiene practices. Because in those areas, the water quality is very deteriorating, and many diseases are associated with the contaminated water. So you can see some of the glimpses from the community workers. You can see that women, due to cultural barrier, we cannot show their pictures, but it is just like you can see that they still put pardas and cover their faces, and even during the training courses. So we try to mobilize women as a trainer so that they can freely discuss and then also they can exchange their ideas freely. So you can see that first aid, search and rescue, all these, they are very poor people. I mentioned to you 1% literacy ratio. So you can imagine that out of these, if you are finding such a kind of volunteers, it is really good contribution from these communities. Next, please. So we have 210 males we train from these courses. So as a total, we have 378. So good thing that 168 female, which is very encouraging in that community. And they then out of that, we fit some predefined criteria to select very serious trainer. And you can see that out of this 378, we could only select 40 people, 40 trainers. We give them further trainer TOTs, so 16 female and 24 male. So these 40, like we selected, is a very cream people who are very serious. We found them in all courses, and then under that criteria, we select these 40 master trainer. Next, please. So you can see that we TOT, we organize. At that level, this is then another city, Peshawar city, we conduct courses. It's a residential course, 7 days course, and participants came without their family members. So it's like we build that capacity repo with them, and then they attend that course and participated very actively. Master trainer, we engage them as I mentioned to you, that first we train them as an assistant trainer, and then later on we train them as a master trainer. So you can see that they participated in different courses. In Pakistan, you cannot organize courses together. So for female separate courses, for male separate courses, we organize. Next, please. Then we also provide hard components. There are basic health units in those union council level communities. So to build the capacities of the hospitals, the basic health units, we provide them solarization. We are now 24/7 electricity available. We develop the alumni database and also IEC material we develop for them. So you can see this IEC material is in local languages. We distributed among the communities different pictures. It's about the earthquake and then flooding and then fire. So these are all available on the website of NHEPRN also, which is a government National Health Emergency Preparedness and Response Network, and also on the WHO. These are some solarization, some from the communities. Next, please. Is finishing. So in order to, the main question is always sustainability. Once project over, then you train such a number of people. We are in our community, in the NGO sector, we are utilizing them. The main big question is the institutionalization, attach these people with the district government setup. So we try until now, the regular meetings that we are a coordination mechanism we have developed with the district disaster management authorities, with the health department, because they were engaged in all the activities. In health clusters also at the district level, we invite them to share their experiences. So until now, this link is there. But it is also just because of our involvement, we are engaging them. Otherwise, the main question is the government taking the leadership and ownership. That is always question mark. Next, please. There was monitoring from you can see that the visit of the Director General in NHEPRN, WHO office, DHO office, civil defense, all these people in this project implementation, they were involved, and also health clusters. So last two slides on the lesson learned, which we learned from this 2 years project is still there is a scope of work at union council level. There are other union councils also, and the literacy ratio is not different than this union council where 1% is only the literacy ratio. Need to include other nearby vulnerable villages of union council. We are mobilizing resources to spread to other union councils. Need to include hard components like solar ice liner installations, that is request provision of emergency response kit. We train them, we form a health DRM committees also. So we train them also. So we are now trying to find funding that we can provide health emergency response kits to them. We involve them in very effectively in the MHVRA study, where they are together with the disaster management committees. We have this at the grassroots level. We train them and they collect health-related database for us. Next, please. And then also, one of a question in the morning session was also that communities should involve in the, yes, madam, is finishing, is involved in the scientific research. We involve them to conduct water quality samples, and then also in the analysis process, we involve them in the report writing. We involve them on the basis of that. WHO is now running another project in the same area. The formation of union council, these days we have this union council is the above village, that is called union council, is agglomeration of different villages. So union council level disaster management committees now also we are forming. So in the same way we are also health-based DRM committees, which is linking with the disaster management committees, that is we have done. And they are linked with the health department and also other non-government organizations which is working in there, in that district. Union council level health risk assessment, that is also the disaster management committees are conducting, but this health committees are providing information related with health. And then, as I mentioned to you, MFR and CSSR further advanced level training, we are trying to arrange for them through some donors so that we can further build their capacities. So last slide, that M&E report also submitted from the donors. They also realized the need of this extending the community health worker force, and we found them very effective, especially the female community health worker participation, encouraged them to take proactive approach. And they are so much actively involved whenever it's nowadays monsoon season start. So it's a rainy season start. So they are vigilant that what is my role. And they are also know from where I can get this information and to whom I should, from whom I should get information, to whom I should convey informations. So that is before that, they only involve in the health-related components. Professional trainers are available with us. They are eager to disseminate their knowledges. We bring them to different provinces under our different projects and we engage them. But still we request to the district governments to involve them effectively. They are now more organized now, and with the district government they are regularly liaising. And the basic health unit is also self-sufficient and have electrifications. Next, please. Yeah, this was from Health Department, the government of KPK and WHO, and NHEPRN, which is also a government entity at the national level. So thank you very much. If there is any questions, experience which you would like to share, we will be happy to know.
Yeah.
Yes, please. Okay. Yeah, please.
Go ahead.
Okay, I'm very interested in what you had to say and the points that you raised. One of the things in the experience that we've done with these things is that a lot of what gets done is corrective, and looking at identifying. A lot of what's done is corrective and looking at the risk assessments of identifying what happened before. One of the great things about having local level capacity and the capacity of community health workers is the perspective ability, because they're at the local level and they can identify change. Part of this can be built into early warning, early action, because they can be the ones on the ground to notice when things are changing and build that into triggering mechanisms for warning and then being a part of the action solution. But also for the long-term adaptive change, to be able to identify how things are changing rapidly and build that into the adaptive system is important as this develops. So I think it's a great selling point, but also something great to be building into the system of what's being done.
Thank you very much. In fact, one thing I forget also, that not only risk assessment, they have developed 5 years risk reduction plan at the community in health perspective. So you can see that now they have like in some certain direction in which they are moving. No? Earlier they don't know about this. So we developed that and we distributed among the health department, WHO and the government health department, and also volunteer the other NGOs that look, they have done this work. It is a small plan, but even it is very effective plan. And we try go time to time that how much progress has been achieved on that plan. Thank you very much. Yeah, it's a very important point. Yes, madam.
In some countries, there's parallel organization, like there's village committees on disaster management, and then there are village health workers. So in your communities, are they one and the same? The health workers are also performing the duties and responsibilities of disaster risk managers.
Yeah, a very important question. Thank you very much. Nowadays, like it's disaster management is national level setup is there, provincial level setup is there, district level setup is there. Now at the grassroots level, that is establishing. At this moment, NGOs are actively involved, but then the government is also now taking the responsibilities. The good thing that these community volunteers are member of the disaster management committees also, but then also they are part of the health. There are like three tiers where a lot of work is done in Pakistan: school-based DRM and health-based DRM and then disaster management. These are three we try to integrate. So the volunteers will be from health committees also, but then also they are part of the disaster management committees also. So meetings, when they are attending, they know that what we discussed there and what is we are going to discuss here. So that is, we have seen a positive approach that they know their importance and they are participating equally. But yes, from the government sector, this is not that much, unfortunately. Until now, we try to mobilize, but they never come for the community level meetings. Yes, please.
Yeah. I just want to really appreciate this kind of effort, no, from the perspective of my country in the Philippines, because most barangay health workers are women.
Yeah.
And I have seen this very good effort to be replicated, no? And in fact, I'm thinking how I can creatively copy this shamelessly.
Yeah.
Why? Because first, we have three important sectors that are being covered by the BHW. Women, in my perspective, in our perspective, most BHW are women, so they can easily influence the family preparedness thing, the child-centered thing, and of course the community-managed DRR.
Yeah.
So maybe I can have the references so that
Please.
from the government, local government point of view, we can creatively get this kind of good practice and have this shared to my province at
Very
least.
good. It is like just we follow the CBDRM process. Zan know about that very well. We follow that CBDRM process and then we fit in where we can fit the health component so that they are thinking from their own perspective, but then they are effective members of the disaster management. So please feel free to use that book and then you can contextualize it in your country need. Yes, please.
Would it be possible to scale up by more intense advocacy and lobbying towards the higher governmental levels? I mean, because you're talking about district level, but maybe province or national level, and have the development of a joint curriculum or so? Because I think otherwise it will remain like well-meant but localized attempts of integration. But if you can influence the governmental process, it's probably much more effective.
Very important question. Thank you very much. Very important question. I was also part of that one UNDRM joint program which we initiated after 2008, after 2005 earthquake. So we work in 10 ministries, means